Welcome to Chapter 2, where we start talking about the review of the basic principles of pharmacology. Objectives are outlined there, studying the factors that influence drug response, drug receptor binding, and explaining the 4 processes of pharmacokinetics, which is how the drug works within the body: absorption, distribution, metabolism, and excretion. So studying of drugs and their actions is essentially what pharmacology is. Pharmacologists are those who study drugs and their actions, consider a drug to be any chemical substance that produces a measurable biological response. Drugs include not only the prescription drugs we have, right, but also non-prescriptions, herbals, botanicals, poisons. By the definition of a drug, a lot of things are included. A convenient administration and duration of action, established dose, immediate onset of action, production of a single desired biological action, dosage unaffected by disease state, and it will help improve longevity and quality of life is what we ideally are looking for when we are developing drugs. Just saying those out loud, I think it's obvious that we don't always hit all of those, right? There's always some positives and negatives to the drugs that we use. Not all of them are going to be perfect, and you oftentimes have to outweigh the risk versus benefit of a medicine. New drugs are developed by pharmaceutical companies. And really, well, at the end of the day, drugs are made to make money. It is a very financially driven market. It has been taken over, in my opinion, by a financial gain and not what is good for the human being and human and mankind. And that leads to all sorts of complications and challenges when we're talking about prescriptions and medications. However, there is, within that arena of developing new drugs, there are these certain stages and procedures that they go through. So the preclinical stage is the animal studies. The identification of the promising drugs and testing in animals occur. The pharmaceutical companies will identify a target drug, starting sometimes with an ingredient isolated from a plant or sometimes an organism, like in antibiotics. And then they'll find something that has a desirable property that they're trying to obtain. Sometimes they'll have a molecular target identified in the body to produce the desired response. Sometimes they have a disease in mind that needs a specific treatment. It is common for the companies to enlist medical chemists who specialize in designing and synthesizing these new drugs. Each drug has a small difference in its chemical structure, and that will change its drug properties. Many drugs are examined as pharmaceutical companies seek the elusive perfect drug with just the right combination of properties. Typically, preclinical studies are performed on cells or on isolated tissues and organs, and they're in lab animals. Drugs approved by the FDA must be both safe and effective and are screened by pharmacologists specializing in various aspects of drug activity. During the clinical stage of a new drug, the pharmaceutical companies must establish the safety and effectiveness of the new drug in humans. So phase 1 clinical trials, right? We're looking to establish safety and identify biological effects. So they are looking to establish the biological effects in a small number of healthy patients, as well as safe doses and the pharmacokinetics. So we are doing now phase 1 clinical trials are with humans, right? During phase 2 clinical trials, the new drugs are used to treat disease in a small number of patients and establish the potential of the drug to improve patient outcomes. So now we're starting to see, does it work or not? We're trying to prove its efficacy. If the drug then still looks promising, it'll continue to progress to phase 3 clinical trials, and they compare the new drug to a standard therapy in a larger number of patients studied in populations across the country. So their randomized clinical trials will compare the new drug to a standard therapy or a placebo. New drugs must be at least as good as, and hopefully better than, other available therapies. So if a drug is going to die, if you will, in the development process, if during phase 3 they work okay, but if we already have drugs on the market that work better, they're not going to proceed to being approved by the FDA and put out for use. After the FDA then approves them, the drugs are going to continuously be monitored through post-marketing surveillance, which is where you and I can come in, where health professionals are encouraged to report adverse events. And then those events are studied by both the pharmaceutical companies and the FDA. During clinical trials, only several thousand patients receive the new drug. But then during post-marketing surveillance, a very large population of patients can receive the drug. And so when we expand from a couple thousand to 100,000s of people on it, that is sometimes when new additional adverse effects can be revealed. And so there are drugs that come off the market after post-marketing surveillance identifies a problem. Pharmacogenomics is the study of how the patient variations in drug targets or metabolism will affect the drug therapy. Pharmacogenomic studies performed during the post-marketing phase can identify biological factors responsible for predictable beneficial or adverse effects in individuals. The book then goes into talking about drug responses. So we're going to talk about dose response curves, the type of drug responses, expressing drug responses, the drug selectivity, drug responses in the real world, and then the differences between brand and generic drugs. Okay, so the dose response curve is what your book first begins to talk about. And this talks about the relationship between the drug dose and the magnitude of effect. That makes sense. So we want to see how the chemical interaction works and what we get as how big of the effect we get. The higher the concentration of a drug at its site of action, the more concentrated it is or saturated at those receptors, the more the drug will bind to those receptors, and thence the greater the response will be. Doses below the curve do not produce a pharmacological response, and doses above the curve do not produce much additional pharmacologic response. And then we may actually get into toxic levels. So you want to fit into, it's like a bell curve. We want to get that majority within the bell. We don't want to be too low. We don't want to be too high. There are two different types of drug responses. We have graded or quantile. Graded means that we have a targeted number, a concrete number that we can grade or record. The examples your book talks about are blood pressure or heart rate, right? I can give you a drug and I can measure and grade that drug for heart rate brought your heart rate from 120 down to 70. Okay, or maybe the next person it came down to 80. We can grade that biological effect because it can be measured. And we can then use to see what is the maximum responding capacity. Okay, so if I know that 25 milligrams of metoprolol brings your heart rate down to 90, well, what does 50 do? Oh, well, 50 milligrams brought your heart rate down to 60, but 100 milligrams of metoprolol brought your heart rate down to 40. So now we know 50 is your right number, for example. Quantile means a yes or no effect happens. So one of the things the book talks about is like pregnancy. Contraceptives either work or they don't. You either get pregnant or you don't, right? So the effectiveness of how the drug works, the drug response is someone's either pregnant or they're not. They also talk about the example of seizures. Seizures are also considered to be a quantile response because we would give somebody an anti-seizure medicine and we'd want them to say, you either are having seizures or you're not. But it also could be somewhat graded because we could also say, well, yes, you had a seizure, but you used to have 10 a day, and now you're having 2 a week. So we would still say that we're getting a good response in what we want, even though we didn't get a yes or no change, but we did get a decrease in frequency. Expressing drug responses. So we want to have a relationship that we can understand between the dose or the concentration and the drug effects. So we usually talk about a dose response curve. Oftentimes you'll see graphs of drug responses, which will show the response on the vertical axis and the concentration on the horizontal axis. Okay, the dose response curves provide information on the relationship between the dose or the concentration and then the response from one or more drugs. Pharmacologists will compare drugs and their actions in several ways. We'll be looking at potency, efficacy, and intrinsic activity. So if it's potent, how much of the drug is needed to produce a biological effect? So potency is not related to dosage, okay? So they're a little bit different concept. You can have a very quote unquote potent drug because you only need one little drop of it and you get this huge biological effect. That is a drug that we say is very potent. Potency is talking about the amount of the drug that gives the great effect. Okay. Whether or not the drug itself gives a great effect is not what we're looking for potency. That's a different thing. That's the efficacy. Potency is when we're talking about the volume of drug needed to get that effect. So if a drug is very potent, we say be really careful. You only need a tiny amount to get a big effect. But I could say that we use these words incorrectly is what I'm getting at, because sometimes I'll hear people say steroids are very potent drugs. They work really well for rashes. No, that's not what the potency means. Okay, potency is talking about how much of the quantity of the drug is needed. Whereas if something is really effective and its efficacy, they really are effective. The effects we get from that are great. They work really well. So potency and efficacy are not the same thing when we're talking about drug responses. Then the intrinsic activity is the ability of the drug to produce maximum stimulation of the occupied receptors. Okay. So I look at intrinsic activity describes the ability of the drug to produce a response once it has occupied its specific receptors. So some drugs produce the maximum receptor stimulation once they occupy receptors. Their response is limited by how many drug molecules occupy each receptor site. So other drugs can have a lower intrinsic activity. They can occupy the same number of receptors, but will produce a lesser response. So intrinsic activity is the ability of the drug to produce the maximum stimulation of occupied receptors. I'm going to jump over here to osmosis and listen to a little bit of this clip to discuss further.
Now, the way a medication and receptor interact with each other is ruled by two main principles. Affinity is how strongly a medication binds to its receptor. This is mainly determined by the strength of the chemical bond between the two. The higher the affinity, the higher the potency, which is the amount of medication needed to elicit an effect. So, medications with high affinity can produce an effect at a lower dose. After the medication binds to its receptor, it must also be able to activate that receptor. This ability is known as intrinsic activity. Ultimately, the intensity of response to the medication depends on both the number of receptors bound to the medication as well as its intrinsic activity. The maximal effect the medication can produce is called the efficacy. Alright, so now let's plot all this into a nice graph to show the relationship between the amount of a medication given, also known as the dose, on the x-axis, usually on a logarithmic scale, with the response produced on the y-axis. What we get is an S-shaped curve, called the dose-response curve. At first, the curve is more or less flat, and that's because the dose is too low, so not enough receptors to bind to the medication to cause a significant response. As the dose increases, though, more receptor medication complexes form, so the response to the medication climbs upward. This is described as a graded dose-response relationship. Eventually, we reach a point where all the receptors get occupied, so the curve starts to flatten out. This is where the maximum response or effect, abbreviated as Emax, is achieved, which is a measure of the medication's efficacy. Now, if we move to the point where 50% of the maximum effect is produced, The effective dose of the medication producing this effect, known as ED50, marks its potency. So the smaller the ED50, the less it takes to get halfway of the maximum effect, so the more potent that medication is. To illustrate this, let's plot the dose-response curves of two medications, medication A and medication B, on the same graph. Notice that both reach the same maximum effect on the y-axis, so the same efficacy. However, on the x-axis, the dose ED50 required to produce 50% of that effect is much lower for medication A than medication B, meaning medication A is a lot more potent than B. In other words, the closer the curve is to the left, the higher the potency is. Now let's look at two other medications, C and D. Medication C achieves a higher maximum effect on the y-axis, meaning that it's more efficacious than D. In other words, the higher the curve, the higher the efficacy. At the same time, though, on the x-axis, the dose ED50 for 50% of that effect is the same for both, so they're equally potent. Alright, as a quick recap. Medications produce their effects by interacting with receptors, either intracellular or extracellular ones, including ligand-gated ion channels, G-protein-linked receptors, and enzyme-linked receptors. These interactions are characterized by the medication's specificity for the receptor, affinity or strong binding with the receptor, and intrinsic activity, or ability to activate it, which in turn determine its potency, or the dose needed to produce an effect, and efficacy, or the maximum effect the medication can produce.
Those videos can be really helpful to give an illustration and really do that visual component for us. Next, we talk about drug selectivity. So that's the ratio of the dose producing undesired effects to the dose producing the desired effects. So it kind of spoke about that in that previous video. The minimum effective concentration is the level below which therapeutic effects will not occur. And then you have the minimum toxic concentration, and that's the level above which you will begin to have toxic effects. When we talk about a therapeutic index, that is the ratio of the MEC and MTC put together. So it's the ratio of the lethal dose to the therapeutic dose. There's some limits to the idea of the therapeutic index because it uses death, a very unacceptable adverse effect, from the animal studies. So that's kind of problematic. The therapeutic index of drugs that are today on the market is, of course, always greater than 1, because if you have a therapeutic index of less than 1, that means that the drug will kill you before it's going to help you. So the therapeutic index is going to always be greater than 1. An example your book talks about is that there are some drugs with a small therapeutic index, meaning the distance between the effect, the level that you need to get an effect, and the level that is going to be toxic is very thin. There's not a lot of space in between those two. So maybe it's a therapeutic index of like 2. But there are some drugs like penicillin, which has about a therapeutic index of 6,000. Like it's really hard to be toxic with penicillin. You may get sick as a dog, but if you got a double dose of penicillin, for example, it's not going to kill you. Whereas a double dose of things like warfarin could have a really bad outcome, or lithium could have a really bad outcome. Those drugs are very narrow therapeutic index is how we describe those. Talking about the drug response in the real world. So we have a dose-effect relationship within the real world. So this theoretical representation of how drugs produce effects in clinical practice. The drug concentration is the x-axis, and that increases from left to right. Some patients will respond at low dosages, either because of a placebo effect or sensitivity to the drug. As the drug concentrations increase, the greater number of patients will respond favorably, but you will have some that respond adversely. So at some dose or concentration, The presence of your toxic effects precludes the use of the higher dose in patients. Brand names versus generic. Woohoo! It's always a hot topic. New drugs are patented to protect the innovator for a period of time. So only that person that created the drug and branded it can create it. So that's their big time to make money. So the brand name of the drug is usually more expensive. The new drugs then are given a generic name that anyone can use to market the drug, but the innovative companies will create a brand name that only they can use. So during the years after they release their drug, it is marketed under their brand name. Example, Plavix versus clopidogrel. Plavix was the brand name. Once the patent on the original drug expires, other companies can then start producing clopidogrel, as an example. They can produce drugs that are designed to imitate the brand name product. Once the competition is allowed, generic manufacturers will formulate similar dosage forms with the same active ingredient and the same amount as the branded product. Because brand name and generics contain the same active ingredient, the body treats the two exactly the same. Differences between brand name and generic preparations can occur in the inactive ingredients, such as when they produce the tablet or the capsule, what kind of fillers they use, maybe what kind of coloring they add. Generic products are supposed, in quotation marks, to provide patients with the same dose as the brand names. Differences between brand name and generic name result from a variation in the time it takes for the formulation to break apart in the stomach and dissolve before absorption. There can be differences in the speed rate of the absorption. So the FDA rates generic formulations in its Orange Book, and products with an AB rating are considered to be similar enough to use the generic substitutes for the brand name. Brand name and generics in which the drug is given in a solution form, such as injectables, are always similar because we're not needing to deal with how they're digested and absorbed. So to go and talk about receptors, let's jump back to our osmosis video from before and hear a little more.
All right, so in order to have an effect, most medications have to reach their target cells and bind to a receptor. Receptors are specialized proteins both on the cell membrane and inside the cell that can bind to a ligand and get triggered to alter their shape or activity. This gives rise to a signal cascade of intracellular molecules, which are the second messengers, which ultimately results in some change in the cell's function. Intracellular receptors are typically found in the cytoplasm or nucleus of the cell, and recognize small hydrophobic ligands, or water-hating ligands. These include molecules like steroids, which are happy to diffuse across the phospholipid membrane. Once bound to their ligand, the receptor-ligand complex attaches to specific DNA sequences that activate or inhibit specific genes. On the cell membrane are cell surface receptors, which are embedded into the plasma membrane and bind to ligands too large or hydrophilic to pass through. Hydrophilic meaning water-loving. Based on their structure and properties, cell surface receptors fall into three main types. First are ligand-gated ion channels, which form channels or pores that are generally closed, but then open up once they bind a specific ligand. They allow ions like chloride, calcium, sodium, and potassium to passively flow into the cell, down their gradient, and trigger the signaling pathway. Next are the G-protein coupled receptors, also known as 7-pass transmembrane receptors, which means they're really long proteins that have one end that sits outside the cell, and then the snake-like protein dips in and out of the cell membrane 7 times, and finally ends on the inside of the cell. The ligand binds to the end sitting outside the cell, and the end of the protein that's within the cell activates guanine nucleotide binding proteins, or G proteins, which contain an alpha, beta, and gamma subunit. Normally, the alpha subunit binds to guanosine diphosphate, or a GDP molecule, and the G protein is inactive. When a ligand binds to the receptor, the G protein changes shape, causing the alpha subunit to release the GDP and allowing a guanosine triphosphate, or GTP, to bind. This causes the alpha subunit to detach and trigger other proteins in the signaling pathway. Broadly speaking, there are 3 types of G proteins: GQ, GI, and GS. Each type has its own kind of alpha subunit. The GQ protein activates the enzyme phospholipase C, which cleaves a phospholipid called phosphatidylinositol 4,5-bisphosphate into inositol triphosphate and diacylglycerol. On the other hand, protein GS and GI stimulate or inhibit, respectively, the enzyme adenylate cyclase, which takes adenosine triphosphate, or ATP, and removes two phosphate molecules and transforms it into cyclic adenosine monophosphate, or CAMP. Inositol triphosphate, diacylglycerol, and CAMP then go on to stimulate and inhibit different sets of enzymes and molecular pathways. Finally, there are enzyme-coupled receptors. These are usually single-pass transmembrane proteins, meaning that they only have one transmembrane segment. The extracellular end of these receptors bind to ligands, and their intracellular end has enzyme activity. The enzymatic domain is usually a protein kinase, which phosphorylates other molecules. When a ligand binds, it triggers a conformational change in the enzymatic domain to form high-affinity binding sites for the second messengers. These second messengers get phosphorylated by the tyrosine kinases before heading off to activate other proteins in the signal pathway. Alright, so every cell has a unique combination of many different types of receptors. And in theory, each medication is specific to a particular receptor, just like each key fits into and opens a particular lock. This is described as a medication's specificity. In reality, though, no drug is 100% specific, meaning it could also bind to other receptors that are similar to its intended target, which is why all medications cause side effects. Now, the way a medication and receptor interact with each other is ruled by two main principles. Affinity is how strongly a medication binds to its receptor. This is mainly determined by the strength of the chemical bond between the two.
Full video again to help explain the different receptors. Your book does not go into that detailed in some of these, but the first one they talk about is the ion channel receptors. And so they will transmit signals across the cell membrane by increasing the flow of ions and then altering the electrical potential or separation of the charged ions across the membrane. We talked about this in your pathophysiology. Ion channel receptors can produce responses with rapid onset and short duration. So the example the book gives is activation of the ion channels by nicotinic receptors causes muscle contraction. Muscle movement must start immediately and will stop at will to be effective. And they talked about receptor-coupled G proteins. Several guanine nucleotide regulatory proteins are present in cell membranes. And the osmosis talked about this. Receptors are activated when the specific drugs interact with the binding site, producing a conformational change, a sort of twist in the G protein. The receptor activation then produces intracellular changes in the binding of the G protein receptor to other proteins that control the response through other molecules called second messengers. So those second messengers are those things like the CAMP or the phosphoinositides. Each can be produced as a result of the stimulating different G protein linked receptors. The G proteins are made up of the three major subunits, alpha, beta, and gamma. They have minor variations of each subunit, and that can result in a great deal of variation in G proteins just from the different combinations of alpha, beta, and gamma subunits. Receptors coupled to G proteins mediate the level of second messengers following the extracellular interaction of the drug with the receptor. For example, beta adrenoceptors mediate the effects of epinephrine, or adrenaline, on the heart and make it beat faster and stronger. They talked about the transmembrane receptors, and in your book they talk about these as well. When an active hormone binds to the extracellular binding site, the receptor conformation changes and two receptors bind to each other, activating the enzyme and sustaining the effect. Intracellular receptors regulating the gene expression. Then the different enzymes. Those enzymes are the biological molecules that encourage specific chemical reactions in the body. The example they talk about is that the enzyme acetylcholinesterase breaks a chemical bond into ACH to terminate its action and produce the acetic acid and choline. Next, they talked about the drug action at receptors. So this is another important thing we're going to stop and make sure that we talk a lot about, because I want you to make sure you understand this, because it can be very confusing for people because the terminology really can mess people up. So let's go back to osmosis and watch pharmacodynamics, and they help us understand the different action at the receptors, whether it's an agonist, a partial agonist, or an antagonist. So let's watch.
Pharmacodynamics refers to the mechanisms and effects of medications within the body. Or more simply, it's what medications do to the body and how they do it. Alright, so in order to have an effect, many medications have to reach their target cells and bind to a receptor. Receptors are specialized proteins found inside the cell or on its membrane. When they bind to a signal molecule called a ligand, they can alter their shape or activity, which ultimately results in some change in the cell's activity or behavior. You can imagine the ligand as the key that fits into the lock, which is the receptor, causing it to open or activate. Now, depending on the effect a medication has on its receptor, they are often divided into two major categories: agonists and antagonists. An agonist is a medication that mimics the action of the signal ligand by binding to and activating a receptor. On the other hand, an antagonist is a medication that typically binds to a receptor without activating them, but instead decreases the receptor's ability to be activated by another agonist. Okay. Now, the maximal effect or response an agonist can produce, abbreviated as Emax, is determined both by the number of receptors bound to the agonist, which depends mainly on the amount of the agonist given, also known as dose, as well as its intrinsic activity, which is the ability of the agonist to fully or partially activate its receptors. Let's plot all this into a nice graph to show the relationship between the dose given, on the x-axis, usually on a logarithmic scale, and the response produced on the y-axis. So full agonists, upon binding to the receptor at high doses, are capable of producing a maximal response of 100% Emax on the y-axis. This represents the point when all available receptors are bound to an agonist. In contrast, partial agonists, even at very high doses, when they occupy all of the receptors, result in a smaller response, so their Emax will be lower. For example, a 70% response would shift the curve downwards. Now, let's say a partial agonist is used at the same time with a full agonist and they compete for the same receptors. If we increase the dose of the full agonist, it will displace the partial agonist from the receptor and the maximal response will still be achieved. So the dose-response curve will shift to the right without affecting Emax, but the dose required to achieve 50% of the maximum effect, also known as effective dose ED50, will be increased. In other words, when a partial antagonist and a full agonist of the same receptor are present together, then the full agonist's potency, which is the dose of agonist needed to elicit a maximal response, will be decreased, but the full agonist's efficacy, which is the maximal effect that an agonist can produce, will stay the same. Alright. At the other end of the spectrum, antagonists can be divided into competitive antagonists and non-competitive antagonists. Now, a competitive antagonist is a medication that reversibly binds to the same receptor site where an agonist binds, but it does not activate it. Competitive antagonists usually bind to the receptor in a reversible way, meaning that they bind and dissociate from it pretty fast. So when they unbind, it's more likely for one of the ligands to bind. So the inhibition caused can be overcome when there are more ligands floating around. This is sometimes referred to as surmountability. Now, on the graph, competitive antagonists typically shift the curve to the right without affecting Emax, but increase the effective dose ED50. So, competitive antagonists decrease the agonist potency, but do not affect the agonist efficacy. On the other hand, non-competitive antagonists don't bind to the same site as an agonist. They bind to a spot called an allosteric site. When they bind, it causes the shape of the receptor to alter in such a way that the ligand can no longer recognize it as a binding site. And even if it does manage to bind, it won't be able to produce the agonist effect. Now, binding of a non-competitive antagonist to the receptor is either irreversible or it dissociates very slowly. This means that the receptor will not activate no matter how many agonists are around. In other words, this type of antagonism is not surmountable. What we see on a graph is that the dose-response curve won't shift, so the ED50 won't change, but the slope and peak, and thus the maximal effect Emax that can be achieved by any dose of an agonist would be reduced. In other words, non-competitive antagonists reduce agonist efficacy without affecting agonist potency. All right, as a quick recap, agonists activate receptors and can be divided into full agonists, which can produce a maximal response, and partial agonists, which can only produce a submaximal response. Antagonists prevent receptor activation and can be competitive, meaning they bind reversibly to the same agonist binding site, and non-competitive, meaning they bind irreversibly to the same agonist binding site or to a different allosteric site. Competitive antagonism can be overcome by adding more of the agonist, while non-competitive antagonism cannot.
Be confusing for people. So partial agonists are kind of the ones that I think are harder to understand. So they have the properties that lie between those of a full agonist and then an antagonist. So partial agonists bind to receptors, but when they occupy the receptor, they stimulate only partial or some of the receptors. So they can act as a part agonist and a part antagonist. Partial agonists would require all of the available receptors to produce their full response, and the maximum response for a partial agonist is less than for a full agonist. The example is beta blockers. 3 of the beta blockers that we don't really use. For example, Pindolol. They are partial agonists. So these drugs can block the effects of adrenergic nerves on heart rate, but partial agonist activity keeps the heart rate from falling too low, as might occur following administration of a pure beta adrenoceptor antagonist. Then next, disease states and receptors. The disease states or the drug treatment can selectively alter the number of receptors in various tissues throughout the body. The non-receptor mechanisms are things like anesthetics or sodium bicarb or chelating agents. So most drugs work by binding and interacting with receptors. The receptors determine dose-effective relationships and the structure-activity relationship between the chemical structure with the pharmacological activity. We went through those, but these are the slides that help us understand these different ones. This is a great slide for us to understand the lipid-soluble hormones pass through cell membrane and bind to the intracellular receptors. This is an example of the enzymes, the biological molecules that encourage specific chemical reactions in the body. Our screen there that talks about these different ones. This is what I wanted to find. The disease states that can alter the number of receptors can be things like we're talking a lot about protein, right? So if you're poorly nourished or you're cachectic and you have very little protein, that is a disease state that can alter how the drug is going to work. All right, next we get into ADME, the pharmacokinetics of absorption, distribution, metabolism, and excretion. We talk about absorption first. You'll often hear this referred to as ADME. So we're going to jump over then to our osmosis, and let's listen to their explanation first. I think they do a pretty good job of explaining things. Here we go.
Pharmacokinetics refers to the movement and modification of a medication inside the body. In other words, it's what the body does to a medication and how it does it. Okay, first things first. A medication needs a way to be administered or a route of administration. Depending on the form of the chemical preparation, like a pill, solution, spray, or ointment, and the part of the body being treated, the medication can be administered through various means or routes, such as swallowed by the mouth or orally, injected into a vein or intravenously, injected into a muscle or intramuscularly, inhaled into the lungs, sprayed into the nose or nasally, and applied onto the skin or cutaneously. Once a medication is administered, it first has to be absorbed into the circulation, then distributed throughout the body, metabolized or broken down, and finally excreted in the urine or feces. This process can be broken down into 4 components with the acronym ADME, which stands for absorption, distribution, metabolism, and excretion. Now, the loss of drug through chemical metabolism, which makes it inactive, and through physical excretion out of the body, can together be referred to as elimination. Okay, so let's start with absorption. Absorption is the process of moving the medication from the site of administration into the circulation. With the exception of intravenous administration, a medication will need to cross one or more cell membranes before it reaches the circulation. Movement across the cell membrane can occur via passive transport, which requires no energy, and active transport, which requires energy in the form of adenosine triphosphate, or ATP. 2 types of passive transport are used: facilitated diffusion and passive diffusion. Facilitated diffusion helps larger, water-soluble, and polar medications move across the membrane through transport proteins like channels and carrier proteins. Passive diffusion helps small, lipid-soluble, and nonpolar medications move across the membrane from an area of high concentration to low concentration. But sometimes active transport is needed, meaning that the medication is transported against their concentration gradient. This involves specific carrier proteins that use ATP as a fuel to pump medications into the cell. Now, sometimes medication molecules are so large that the cell resorts to bulk transport, also known as endocytosis, where the cell membrane invaginates and swallows up the medication, forming vesicles. Now, the rate of the absorption, or how quickly this process occurs, as well as the extent of the absorption, or how much of that medication reaches the bloodstream, depend on several factors. One of them is the pH of the environment where absorption takes place. Okay, so most medications are either weak acids or weak bases, and can exist in an uncharged or charged form. The uncharged form is the lipid-soluble, nonpolar one, which happily diffuses through the cell membrane, while the charged form is water-soluble and polar, and thus cannot diffuse through the cell membrane easily. The ratio between the 2 forms is determined by the pH of the environment and the strength of the weak acid or base. The strength is measured by pKa, which is the pH value when concentrations of the uncharged and charged forms equal each other. So, when the charged form of a weak acid, A-, shows up in an acidic environment with a lower pH and plenty of hydrogen H+ ions around, it will grab one of them and turn into its uncharged form, HA. HA can then be readily absorbed across the cell membrane. On the flip side, if the charged form of a weak base, BH+, is placed into an alkaline environment with a higher pH and a lack of hydrogen H+ ions, it's going to give up its own hydrogen H+ ion and become an uncharged B. It can then pass through the cell membrane just like HA. So in other words, weakly acidic medications will be better absorbed in an acidic environment, like the proximal duodenum, in contrast to weakly basic medications, which are more likely to get absorbed in an alkaline environment, like the distal ileum of the small intestine. Note that even though the stomach is acidic, it's not suitable for the absorption of even weak acids, mainly because of its thick mucus layer. Okay, now another factor influencing absorption is the surface area available. A good place for absorption is the small intestine. With its circular folds, villi, and microvilli, the total surface is actually about 250 square meters, the size of a tennis court. Other factors also include the blood supply to the absorption site and the presence of food or other material in the gastrointestinal tract that can either promote or inhibit absorption. So, after a medication is taken by mouth, it gets absorbed through the walls of the small intestine and transported into the liver via the portal vein. Once in the liver, hepatic enzymes work on the medication to metabolize it. This process is known as first-pass metabolism or first-pass effect and is responsible for breaking down most medications into their inactive metabolites, as well as converting certain prodrugs into their active metabolites before entering the general circulation. This, however, means that if a medication is taken orally and it undergoes extensive first-pass metabolism, their concentration in the bloodstream can get so reduced that once they reach their site of action, they can't produce the desired effect. In that case, alternative routes of administration should be considered, including intravenous, intramuscular, transdermal, sublingual, or inhalational administration. What these do is bypass the first pass effect, allowing medications to go straight into the systemic circulation and produce their effect. Okay, so this brings us to the concept of bioavailability. Bioavailability, or F, is actually the fraction of an administered medication that eventually reaches the circulation in the unchanged form. For example, if someone takes 100 milligrams of pantoprazole orally and only 77 milligrams of this is absorbed into the circulation, the bioavailability is 0.77 or 77%. In contrast, if the same 100 milligrams pantoprazole is taken intravenously, all of it goes directly into the circulation, bypassing the gastrointestinal absorption and first-pass metabolism. So medications administered intravenously will always have a bioavailability of 1 or 100%. Let's plot all this into a nice graph to show the relationship between time on the x-axis and the plasma concentration of the medication on the y-axis after both oral and intravenous administration. Thus, bioavailability of an oral medication can be estimated by dividing the area under curve, or AUC for short, of the oral form by the AUC of the intravenous form. And both AUCs need to be corrected by the dose of medication, or D for short, administered orally and intravenously. So the bioavailability F of a medication is AUC oral times D intravenous over AUC intravenous times D oral. Alright, so once the absorption has been completed, we are ready for the distribution of the medication. Distribution is the movement of a medication from the circulation into the body tissues. Once again, the rate and extent of distribution depends on several factors. So one of them is blood supply to different tissues. Medications will be more rapidly distributed to body tissues that receive large amounts of blood supply, like the brain, liver, and kidneys, and less to the tissues with poor blood supply, like the skin and adipose tissue. But for any medication to enter the brain itself, it has to go through the so-called blood-brain barrier, which is strictly regulated. Think of the blood-brain barrier as the brain's bouncer, a highly selective membrane that turns away large, water-soluble medications that are floating around in the blood, while letting in smaller, fat-soluble medications. Similarly, the size and polarity of a medication affects its distribution. So in general, smaller, hydrophobic or lipid-soluble medications can easily cross through the lipid bilayer cell membranes, giving them an
Let's review here. We have properties that will affect the distribution. We have our water or lipid solubility, the size of the molecules, the environment's pH, whether or not they're bound in protein, what transporters they use, and then the volume of distribution. The protein binding we talked about. Drugs passively diffuse when unbound to plasma proteins and are uncharged. But drugs bound to plasma proteins circulate in the bloodstream rather than being redistributed by passive diffusion. Drugs bound to plasma proteins are protected from metabolism and excretion, which helps normalize drug concentrations in the body. Low plasma proteins will result in more unbound drug in circulation, which means then they're not protected from metabolism and excretion. So if you are low on proteins, it can very much change the way that the drugs are distributed in your body. There's a finite number of plasma proteins, and several drugs can bind to the same plasma protein, so they could displace each other, which makes it a higher risk for toxicity, and more drug may be eliminated. Membrane proteins that facilitate movement of the molecules across the cell membranes can transport drugs into, which is an influx, and out of is efflux, the basis for controlling the distribution into protected tissues, right? So we have our blood-brain barrier with the example. The osmosis video does a good job of explaining the volume of distribution. It's important for understanding where the drug is distributed once it's absorbed. So a large volume of distribution reflects low drug plasma concentration, little protein binding, and extensive distribution to body tissues. Water-soluble drugs have a volume of distribution similar to plasma volume, but lipophilic drugs have a very large volume of distribution. So your volume of distribution can be affected by dehydration, obesity, and edema. Talking about metabolism, your book goes into a little bit more detail, I think, than the osmosis video did. So in metabolism, that's when we have the biotransformation involving chemical alterations of the drugs into their metabolites. This typically occurs in the liver, but there's also some metabolism in the kidneys, lungs, skin, and the GI tract. First pass metabolism is a very important concept to understand. So most drugs given orally, so oral administration of drugs will go to the liver and they will be metabolized. And oftentimes this can have a negative effect on how much is available then for distribution to the body. Metabolism by the liver following oral administration is called the first pass metabolism. This is often what can preclude a drug from being given orally. When you hear that the drug cannot be given orally, it has to be given IV, it is probably due to first pass metabolism. The book goes into a little more detail too about the phases of metabolism. They bring up the idea that there's a family of enzymes called the CYP450 or the CYP450 drugs that metabolize. Each of these CYP enzymes is responsible for a single type of metabolic reaction. The book talks about the phases of metabolism, phase 1, phase 2. In phase 1, this is pre-conjugated. The drugs become more water-soluble through oxidation, reduction, or hydrolysis for easier excretion. And then in phase 2, or conjugation, the attachment of the drug to a polar molecule, making it highly water-soluble with little to no pharmacological activity. When you have conjugation to molecules, that makes the metabolites more water-soluble, and they can therefore more easily be excreted by the kidneys. So the presence or activity of these enzymes can influence the pattern of drug activity and also will impact the duration of action for the drug. So the CYP450 or CYP450 is the most thoroughly studied drug metabolism mixed function oxidase reaction. The CYPs transfer electrons from the oxidation of drugs to the electron transport system of the endoplasmic reticulum. There are many forms of the CYPs that are products of separate and distinct genes. Okay, there's all sorts of these. You can see that they can be numbered based on families and then subfamilies. Genetic polymorphisms can change drug metabolic activity and explain why some individuals react differently to medications. We know now that we can check for these genetic polymorphisms and see if you are able to digest and metabolize a drug or not. If you lack the CYP enzyme, or you have certain types of enzymes that make you absorb different drugs differently, metabolize the drugs differently. You will hear about the half-life of drugs. We've learned this in the undergraduate world, but let's review it. Most drugs are present at concentrations below their maximum half-life. Under these conditions, metabolism is related to the drug concentration so that a fixed fraction of the drug is metabolized per hour. Okay, so when you have a half-life, it's how long there's 50% of the drug or more in the body. So at a half-life, if I say a drug has a half-life of 48 hours, you won't begin to see reductions of the concentration of the drug in your bloodstream until after the 48 hours. All right, patterns of metabolism. It's important to remember that metabolism can change the pharmacological activity of the drug. We consider that drugs are pharmacologically active and that metabolism decreases the activity and promotes excretion. Your figure 211 in your book is a nice description of this. We expect to see inactive metabolites that have short half-lives and are rapidly excreted. However, that's not always the case. Prodrugs are inactive compounds that rely on metabolism to become active. Prodrugs have advantages and disadvantages. And that could be an advantage, maybe because of their absorption or distribution. So L-DOPA is a prodrug that is used to treat Parkinson's disease. The problem in Parkinson's disease is a lack of dopamine in the striatum of the brain. Dopamine, however, cannot pass through the blood-brain barrier. So it's ineffective when used to treat the neurotransmitter shortage of dopamine in the brain. However, L-DOPA can pass into the brain and enter into cells, where there it can be converted into dopamine. So we kind of hack the science, so to speak, to get it to the place that it needs to be, and then the chemical reaction can occur, and now the drug can become active. Sounds good. However, prodrugs can also have disadvantages. The book talks about terfenadine. It was one of the first non-sedating antihistamines that was very popular for a while. The first past metabolism biotransformed terfenadine, which is cardiotoxic, into fexofenadine, which is an effective antihistamine. When it was realized that inhibition of the CYP3A4 could result in toxicity and death in some patients, terfenadine was withdrawn and we replaced it with fexofenadine, which is its active metabolite. Other prodrugs are pharmacologically inactive, and they rely then on that biotransformation to an active metabolite. CYP2D6 metabolizes codeine into morphine, which is 12 times more potent of an opioid. Hydrocodone is metabolized to the more potent opioid hydromorphone by CYP2D6 as well. But about 7% of the white population lacks CYP2D6 activity. Administration of a prodrug requiring metabolism by CYP2D6 creates a situation in which the patient is receiving an inactive or poorly active drug. So, in the case of pain relievers, patients may be seeking stronger drugs, not because of abuse, but because the drugs they were given are not being biotransformed into their active metabolites. On the flip side, patients with highly active CYP or CYP2D6 are at a greater risk for opioid toxicity following administration of codeine or hydrocodone. All right, drug interactions. A drug can cause alterations in the enzyme metabolism of another drug by being an inhibitor or an inducer. All right, inhibition occurs through competition of two drugs metabolized by the same enzyme. In inhibition, the drug decreases the production of the enzyme needed for metabolism. Drugs causing enzyme induction make the metabolic pathway work quickly, causing the drug to be deactivated more rapidly. And then finally, last but not least, excretion. Removal of the drug from the body is excretion. Drugs can be typically excreted by the kidneys, but also through the GI tract, the lungs, through sweat and saliva, and via breast milk. So talking about renal excretion, the kidney is the primary organ of excretion for most drugs. The general mechanism of metabolism is to produce drug metabolites that are more water soluble and thus easier for the kidneys to remove from the plasma and excrete in the urine. We know that the kidney is a very complex organ with several important functions, right? The kidney is responsible for excretion of the waste products. It's also responsible for maintenance of fluid and electrolyte balances. Typically, the kidney's strategy is to remove a large volume of plasma and then to take back the substances that the body needs. The resulting waste product is urine. There are also transport mechanisms that can secrete substances into the urine. So production of urine, as a review, begins in the glomerulus of the kidney. The operational unit of the kidney is the nephron. And each of the millions of nephrons begin with the glomerulus. The glomerulus is a specialized area of the nephron, and it's been adapted for ultrafiltration. Ultrafiltration is that process in which the substances in the plasma pass through these small holes, or the pores, in the glomerular capillary membrane, and it's based on their size. The structure of the glomerular capillary membrane permits filtration of smaller molecules while restricting the passage of compounds with larger molecular weights. So as the blood flows through the kidney and encounters the glomerulus, much of the fluid portion of the blood is filtered into the lumen, or the center of the nephron there, and the kidney is exceptionally efficient at what it does. So we have the glomerular filtration rate, which is a very important measure of renal function, and that is the blood flows through the glomeruli in the kidneys per minute, and it gives us that number, which is the GFR. Glomerular filtration is the first step towards producing urine that will have the drugs. Filtration preserves plasma proteins, because those are big, so they don't go into the urine, but they will then remove the free drugs and other waste products from the plasma. The large volume of fluid filtered through the glomerulus is an ideal vehicle for drug removal. So as you have that ultrafiltrate, it's formed, the drugs that are free in plasma, the drugs that are not bound to plasma proteins, are filtered. The filtration may be slower for these large molecule drugs because the size of the pores through which filtration occurs. Very large drugs may not be filtered at all. The pores of the glomerulus contain a fixed negative charge, so filtration may also be affected by the drug's charge. Remember that effects of urine acidity on drug elimination are also at play, and that can have important clinical implications, particularly when manipulated clinically to enhance the elimination of toxic drugs. So urine can be made purposely acidic by administration of ammonium chloride, or it can be made basic by the administration of sodium bicarbonate. All right, tubular reabsorption. In addition to reabsorption by passive diffusion, substances filtered at the glomerulus are reabsorbed by active transport systems located primarily in the proximal tubule of the nephron, which you can see here, our proximal tubule. Active transport is important for our endogenous substances that the body needs to recover from the glomerular filtrate. We need these. We need to hold on to them and have them stay. These include ions, amino acids, and glucose. The active transport systems are located on the luminal cell surface, and the transport substances then into the cell. Then they are passively transported back into the plasma. A small number of substances may be actively reabsorbed. It is more common that drugs acting on tubular secretion do so by inhibiting active transport. Okay? Uricosuric agents such as probenecid inhibit the active reabsorption of uric acid. A really popular class of drugs, which is our SGLT2 inhibitors, so sodium glucose cotransporter 2 inhibitors, such as empagliflozin, are newer diabetic medicines that reduce the reabsorption of glucose. So they produce more loss of glucose in the urine. Substances that are actively reabsorbed can also be actively secreted, and drugs may inhibit both processes. The example the book gives is those low doses of salicylates, like aspirin. Those will inhibit tubular secretion and decrease total urate excretion. But if you have higher doses of aspirin, that will inhibit the tubular reabsorption and result in increased excretion of uric acid. The nephron also contains active secretory systems that transport the drugs from the blood into the lumen of the nephron. There is a transport system that secretes organic anions and one that secretes organic cations. The transporters are present on the plasma side of the tubular cells of the nephron, and they can actively pump the anions or cations into the cell. The substances then pass into the lumen by passive or facilitated transport. The secretory capacity of these transporters can be saturated so that less drug is excreted at high drug concentrations. Active secretory systems for the anions and cations are very important. Anions and cations are strongly bound to plasma proteins and may not be readily excreted by glomerular filtration. So tubular secretion often contributes to the renal elimination of drugs that have short half-lives. Specifically, hydrochlorothiazide, furosemide, and penicillin G are among the substrates for the organic anion transport system. It is very common, we know, to monitor the renal function of our patients. We know that if we have reduced blood flow to the kidneys and the kidneys are not filtering as well, we're going to have to modify our drug dosages. If people are low on protein, that may affect renal excretion as well. When we calculate the creatinine clearance, we also look at height, weight, sex, and age. We often forget about the GI tract excretion, so let's talk about that a little bit here. In the bile, we can excrete things as well. So after being metabolized in the liver, the metabolite is excreted into the bile. Some drugs then can be reabsorbed into the intestine. Enterohepatic cycling decreases the amount of the drug excreted. We also can have things through fecal excretion. In our lungs, in our gas exchange, we can have lungs participate in excreting a drug from the body. Think about general anesthetics. After alcohol consumption, you also can excrete things through the lungs. The rate of excretion based on the respiratory rate and the pulmonary blood flow. That makes sense. In the skin, we can use some drugs on the skin. And some of those, some drugs also can be excreted in our sweat and can cause a rash. We can also have some drugs that can produce changes in taste because they have some salivary excretion as well. We know that drugs can be excreted in breast milk, which is why we have to be conscientious if we have a breastfeeding mother. Breast milk is actually acidic, and so it easily accumulates some more basic drugs, which is kind of terrifying. All right, let's go to our knowledge check. Which of the following describe the processes of pharmacokinetics? ADME, so B, right? Always remember ADME. Which of the following statements are true about the CYP450? A. All right, you guys, you made it through chapter 2. We'll see you again in chapter 3.